So it's my pleasure today to introduce Dr. Jacob Mandell. He is going to be presenting this topic for us today, artificial intelligence and MSK imaging. He is joining us from Massachusetts. He is with Brigham and Women's Hospital, and we're very excited to host him today for the artificial intelligence course.
Great. Thanks so much. It's really an honor to be invited to present here. Over the next 25, 30 minutes or so, I'm just going to give an overview of the current state of AI and MSK imaging. So I'm a musculoskeletal radiologist at Brigham and Women's Hospital in Boston, and I also am the fellowship program director there. So if you're interested in MSK for fellowship, come visit us. Let me know. In terms of housekeeping, no disclosures. I'm a plain old regular radiologist. I have no special experience or expertise in data science aside from an avid interest in it. And so this talk is for regular radiologists or even residents. It's not a data science talk because I wouldn't have any idea what I'm talking about. So introduction to AI and MSK radiology. What is AI? We'll talk about that a little bit. What can it do? Where are we now? And very briefly, in terms of in the field of MSK radiology, AI can do various things as shown by these categories. It can detect things, it can classify or grade things, segment things out, areas of interest, it can measure things. We can use AI for opportunistic screening. AI can assist in image acquisition, either MRI to speed up acquisition or increase resolution, or CT for reducing artifacts. We'll talk about how does AI work, and I'll use my some personal experience of some work we did to demonstrate what goes into creating a simple model for MSK imaging with AI. And then I'll also talk about some other people who are more experienced work in a complex model, and I'll describe the difference between a simple and a complex model. And then what can't AI do? And you'll find various AI-generated, images throughout the talk these are from Flux, so they'll have the little tab here on the bottom. Okay, so starting out, what is AI and MSK imaging? Of course, so the first thing to do is to ask ChatGPT, and it gave me like a 5-paragraph answer, which I didn't even read, so I had to rephrase it, and I said, please be very concise. And then it gave me this, which I thought was pretty good. AI in musculoskeletal imaging uses machine learning to analyze X-rays, MRIs, and CT scans, helping detect conditions like fractures, arthritis, and soft tissue injuries quickly and accurately. It enhances radiologists' efficiency, reduces errors, and improves diagnosis by recognizing patterns in images that might be missed by humans. And, that's pretty nice summary. It's maybe a bit optimistic. I don't think we're there yet, but I think that would be a nice place to be in a few years once the technology kind of percolates into clinical use. But can we trust ChatGPT? Can we trust AI? So I asked the ChatGPT this famous question: how many R's are there in strawberry? And immediately and without any hesitation, it replied that there are 2 R's in the word strawberry. Now, ChatGPT came out with a new model, like in the last few weeks, like the O preview. It actually gets this right. However, it takes about 15 to 20 seconds to think about it. So we'll see. So where are we now? Where are we going? Let's talk about those categories that I briefly mentioned in the beginning, and then I'll get into the nuts and bolts of, how do you actually make a model? So AI, and all of these are examples from the literature without, bogging us down with hundreds and hundreds of references. We'll just talk about broad categories. So lesion detection, detecting if a lesion is present or distinguishing normal from abnormal. So for instance, fractures, wrist, hip, spine, joint dislocations, joint effusions, if in the knee, ACL tear, meniscal tears, osseous mets, other primary bone tumors, sacroiliitis. In all of these situations, AI models have been shown to be as good or even better than expert readers for detection. And I just wanted to highlight this relatively recent meta-analysis that came out in radiology about 2 years ago that looked at 42 different studies for detecting fractures. And they found pooled sensitivity and specificity of about 91, 92% for clinicians and for the AI models. So basically performing equivalent to humans in this meta-analysis across 42 studies. And there's no statistical difference between AI and clinicians. But, a big caveat is these are all individual papers talking about individual fractures. So to my knowledge, there is no model that can detect vertebral body fractures and scaphoid fractures, for instance. Each model has to be trained separately. Okay, so now let's move on to classification and grading. And this usually means evaluating the degree of something, which is often on a continuous scale or differentiating between types of similar disease entity. So for instance, for MR knee, grading of cartilage loss on MRI. And we'll actually talk about this a bit in depth. Grading of spinal stenosis, grading of osteoarthritis, bone age assessment. That's what this image is from here. It's an AI bone age assessment tool. Classification of soft tissue tumors, bone tumors, and grading of rotator cuff tears recently came out as well. Measuring. So AI is quite good at measuring things if you train how to do it. For instance, the notorious Cobb angle of the spine, which is, can be tricky to measure accurately depending on the alignment and the orientation, and you can get a few degrees of variation depending on, where you draw the lines. But AI is pretty reliable for this. Leg alignment, as seen on this image here on the right side of the screen, where the AI measured various parameters after total knee arthroplasty. Hip measurements, the Insel-Salvati ratio, which measures patella alignment. If you have patella alta or patella baja, it can do that automatically, and it just came out, so it's kind of interesting. Segmentation is separating out regions of interest. So for instance, structures in MSK imaging where AI has been shown to be able to reliably segment is the vertebral bodies, the intervertebral disc, even disc herniations and various parameters and structures related to degenerative spine grading, such as the spinal canal, like we see here in the red, the lateral recesses, the nerve roots, the epidural fat. And here we see the intervertebral discs and the disc herniations all reliably segmented out by AI. Opportunistic screening is the very broad field of analyzing images to find parameters that may impact the patient's health, usually not related to why the imaging was obtained. So, for instance, there's a lot of literature on opportunistic screening for osteoporosis. So CT scans obtained for whatever reason, abdominal CT, chest CT for whatever abdominal or chest problems, and then look carefully at the vertebral bodies to evaluate fracture risk and osteoporosis scores. And AI is superbly suited for this. You can see here in this image here, this paper that just came out showed that AI is reliable for segmenting vertebral bodies and evaluating fracture risk from based on osteoporosis on scanners performed from many different manufacturers. You can also use it to evaluate the muscles, either general health outcomes for sarcopenia or specific health outcomes related to post-surgical changes. So for instance, look at the spine, paraspinal muscles, how do people do after spine surgery? Look at the hip girdle muscles, how do people do after total hip arthroplasty? And this is a very active area of research right now. Image acquisition. So either increasing detail in the scan, increasing the speed of the scan, so decreasing scan time, or decreasing artifact are all well-established ways that AI has been used in MSK imaging. And there are a number of commercial products from GE and Siemens, among others, that are routinely used. And we have them in our clinical practice for accelerating MRI scans. So for instance, here's an example image. This is accelerated MRI of the ankle. On the left side of the screen, A, this is approximately 3 times accelerated image, and B and C are 2 non-AI accelerated images. And the image quality, I think, is pretty excellent for both of them. Of course, what structure is this yellow arrow pointing to? This is the ATFL. Here's the PTFL, perineals, and so on. So excellent image quality, or effectively no loss in image quality while maintaining an accelerated scan time. Now, if you look closely, you can find some differences. So for instance, this structure here is a vessel. It doesn't really have much features here on the accelerated image, but you can see that, more clearly on C, there's like 2 low signal intensity lines that go through it. So what's the clinical significance of these tiny changes? We don't really know, but these are FDA approved, these technologies, and they're used commonly, basically throughout the world now. It is accelerated MR image acquisition. Chatbots in clinical use, still pretty experimental. There's some interesting papers that came out recently. There's people are saying it could be used as a clinical decision support tool, you know, provide information. It can give differential diagnosis, things like that. It's hard to do that while maintaining HIPAA and privacy unless you're very careful. And so for the most part, these are not really used clinically that way yet. Other people have suggested using chatbots for simplifying reports that may be full of jargon or technical terms for patients. And this was pretty interesting. This just came out in the European Radiology, where they had ChatGPT and radiology residents and attending radiologists all take 106 test yourself cases from skeletal radiology. And you'll see two ChatGPT results here. One of them did very poorly, like, maybe 10% accuracy. And the other one actually performed almost identically to radiology residents. And so what's the difference between these two? This V version is the vision one, where you can take a picture, send it to ChatGPT, which, by the way, is like amazing for museums, like art museums, natural history museums. Just take a picture of like some bone of like an animal and it'll like tell you what animal it's from and all that stuff. It's pretty amazing. But if you show it radiology images, it actually does terribly. And that kind of makes sense. I guess radiology images weren't really part of its training pool, even if mammoth bones were for whatever reason. However, if you describe the findings in text, like there is a T2 hyperintense mass with this type of enhancements and so on, then it actually does about the same as radiology residents, although not quite as good as board certified radiologists. And you can tell these questions are quite difficult because really even the best are getting about 50% right in the final diagnosis, and everyone's getting a little bit higher about including reasonable things in the differential diagnosis. So, there is certainly potential here, but the vision has a long way to go. Okay, so now let's shift gears. We did like a very whirlwind tour about what the literature has shown us that AI can do in MSK imaging. So now we'll talk about how does AI work? There's a lot of, you don't really have to know. That's kind of the cool thing. Basically, you have an input image that's labeled. So this would be labeled, of course, ACL tear. And then the convolutional neural network extracts complex features, simple features with forward and back propagation, and basically associates those imaging findings with the labels. But, it's okay. Just think of it as like putting a bunch of stuff in a cauldron, letting it cook for a while, and then you have your model. So it's okay to think of it as a black box or a magic cauldron. But the gist of it is you have annotated data, like let's say you're making a model to determine if ACL tears are present or not. So you've got hundreds, thousands, tens of thousands, the more the better, of ACL tear images labeled ACL tear, no ACL tear. Then you feed that to the training, pattern recognition, you get your model. That's basically a simple model. And now we'll go through in a couple minutes each the difference between a simple model and a complex model. So a simple model, you just put your data in and you get your model. I say it like it's so easy. It's not that easy, but that's the gist of it. A complex model, you have to process the data in some way. And then you put that modified annotated data in to make a model. And we'll talk about what the difference is between the simple model and the complex model and in which situation you might need to use what. So we'll start with this quote simple model. And this is some work that we did recently in the last couple of years. Our question was, can AI discriminate rheumatoid arthritis from osteoarthritis on hand x-rays? When first-year residents come to us, this is often kind of the first thing they learn, the various patterns of the arthropathies, as you know by now, that the osteoarthritis tends to affect the distal joints of the hand, DIPs, and the thumb CMC. And, rheumatoid arthritis affects the MCPs and the carpus more. And it would be unusual for rheumatoid arthritis to involve the thumb MCP, unusual for it to involve like the index DIP, for instance. Okay, so that's our question. Can AI distinguish rheumatoid arthritis from osteoarthritis on hand x-rays? So we needed to come up with training data. So we used about 9,000, 10,000, actually 9,700 hand radiographs, which were obtained from PACS with their reports. And then if you go back to this page here, if you look at the authors list, Ian is actually a fourth-year resident now, but he's really brilliant at AI. It's actually nationally recognized with winning various AI competitions. So he has his own workstation that he built, and Ian and Lauren Ma were like really fundamental to making this paperwork with contributions that were invaluable from every one of the authors. Okay, so Ian was able to get 9,700 hand X-rays from PACS with their reports, and then did natural language processing to establish the ground truth. So the natural language processing was able to basically take the verbiage of the report and classify it into normal, osteoarthritis present, or rheumatoid arthritis present. Then, based on that, fed that into the model. And this was a custom machine, dual GPU workstation that ran kind of on the overnight timescale to create the model. And then after the model was made, we had to test how well does it work. So we selected 250 radiographs pseudo-randomly, intentionally over-selecting for disease positivity because rheumatoid arthritis is rare of the 9,700 consecutively performed hand X-rays. And then these were read by 2 or 3 radiologists, 3 in the case of a discrepancy, or 2 if there wasn't a discrepancy, to establish kind of the ground truth to see how the model did. Okay, so this is just some data that we're dealing with, so you get a sense of the numbers required. Of course, none of these data individually are important, but I just wanted to give a flavor for how many exams you need. In the training set, there were 9,714 exams, which made 30,000 plus images. And we decided, let's just train it on the PA view of the hand because the oblique and the lateral view may be lower yield. And you can see that of the training data set, importantly here, 5% or so had rheumatoid arthritis. And then we selected 250 exams, and then you can see we inflated the amount of rheumatoid arthritis and osteoarthritis because otherwise there would just be a handful of rheumatoid arthritis cases in these exams. And, it's kind of time consuming to read 250 X-ray exams. How did the model do? So you can see that the area under the curve is actually quite high. It's either 0.95 or 0.97, depending on if it's differentiating negative from RA or OA, or just RA from negative or OA. And this matrix here shows you that this on the left axis, or the vertical axis, is the true label, and the horizontal axis is the predicted label. You can see that the vast majority of cases, the true label is consistent with the predicted label. And so the model had quite very high accuracy with a high area under the curve. All right, so we had this data, but now you still have to do we accept this? Is this it? Can we make things any better? And so what can you think of that, can possibly make things better? For instance, you can change the image resolution that the data is using to train. You can use just the PA view, or you can use 3 views. You can do additional pre-training. What this means is you kind of pre-train the model on existing publicly available data sets of various X-rays to get the model kind of used to looking at X-rays. And it turns out none of these modifications were able to make any improvements whatsoever. Ian felt that this was due to some technical factors, that when you increase the image size, it dramatically increases the amount of memory required, and you have to run things in more individual batches, which makes it harder for the model to work. Interesting, the only thing that changed the results was decreasing the image size. So our base model uses about 1024 by 1024 pixels, which is relatively high resolution, but still lower resolution than the native X-ray. If you decrease that to tiny, to 256 by 256, you substantially decrease the model accuracy, but none of the other changes made any impact. So we went with the original model, but we reported all of the stuff that we did. And I really like these images. So these are called class activation maps. They're like heat maps. They show where the model is finding the areas of discrimination. And this is really just out of a first-year radiology textbook for differentiating rheumatoid arthritis for osteoarthritis. So for instance, on this left image, these are the classic areas where the model looked for osteoarthritis, where the model found osteoarthritis. Thumb CMC, thumb IP, index DIP, to a lesser extent, like the middle and ring finger DIPs. That's really just classic from like arthritis and black and white textbook. And then if you look where the model found rheumatoid arthritis, it's the carpus and then the metacarpals, MCPs, the second and third MCPs. And, for instance, the thumb MCP didn't light it up at all in rheumatoid arthritis. Okay, so that's a simple model. You feed a lot of data that's all annotated into the model. You run the model, you see how you can improve it. Ideally, you would then gain something from the model by looking at the class activation maps to kind of know what the model's doing. Now we'll talk a little bit about a complex model. Like, so for instance, what if the data isn't neatly contained on a single image? Like, you can look at a PA of a hand and really know if it's like osteoarthritis and where the osteoarthritis is. But there's many situations where that's not the case. Or what if the area is an irregular shape where you need multiple, slices on an MR to see it? And so what musculoskeletal structure is notoriously difficult to image? Cartilage. Okay, so let's talk about cartilage of the knee, and really a very brilliant paper that came out several years ago, but to me, this paper is like the hallmark of creating a complex model. So what are the problems with cartilage, with you making an AI model to evaluate cartilage? It's thin and curved. It takes up just a small percentage of pixels. You have to assess it as a 3D structure, but deep learning algorithms only work on 2D images. There's high variability. Even among arthroscopists, there's high variability in terms of how cartilage lesions are described. And there are also clues to cartilage lesions outside the cartilage. There could be subchondral edema, meniscal tears, osteophytes, that if you kind of pick out the cartilage separately, you might lose these features. So let's just visualize it. This is a normal sagittal PD fat set knee MR. And, I highlighted the patellar, the femoral, and the tibial cartilage. And then with Photoshop, you can easily calculate what percentage of pixels all these features are. So the patella cartilage is 2% of the pixels in this image, and so on. The femoral cartilage, 5%, tibial cartilage, 2.5%. All of the cartilage in the knee is less than 10% of the pixels. So you probably have a very low success rate of creating an accurate model if you just feed it the straight image, because 90% of the image is not related. Now, there might be other things that could confound it, like we talk about osteophytes and meniscal tears, but that's not really directly looking at the model. There's like a classic case in the early days of like AI where a paper came out as, oh, we have very high accuracy for finding lung nodules. It turned out the model wasn't looking at the lung nodules, but there was like an annotation on the bottom that, said that so-and-so like lung cancer clinic or whatever. And it was just picking up that when you look at the class activation map. So you can't really feed it the whole image because the data is too small. So you have to somehow separate out the cartilage. So first, let's talk about the interreader variability as another confounding factor, and then we'll talk about how to separate the cartilage. As you've probably known from reading out with your MSK attendings, everyone reads cartilage differently. So someone might say, oh yeah, that's like a less than 50% defect. And then, the same resident reading with a different attending, the same case, the attending might say, oh, that's like a near full thickness defect, or that's like normal. So we run into this all the time. And the reason is because the literature shows there's just huge disagreements in reading the cartilage. CT arthroscopy, which is an excellent test for looking at the cartilage, kappa value, which is a measure of agreement. 1 is perfect agreement, 0 is no agreement, 0.35. Some earlier work we did showed, about 0.55 kappa with no difference, 3 Tesla, 1.5 Tesla. Others have shown difference, 3 Tesla, 1.5 Tesla. So the modality can differ. The observer can differ just depending on their mood or whatever. Even direct visualization by arthroscopists show a kappa of like 0.6 or so. Okay, so you have these cartilage areas that are very tiny, use a small percentage of the pixels with high disagreement. And also, look at these cases. These are actual clinical cases. Here we have an osteochondral lesion of the femur. There's like the undulation, irregularity of the subchondral bone plate, subchondral edema, like all this fissuring in the cartilage. And arthroscopy 26 days later, the arthroscopy report just basically past all the cartilage, so is everything normal. Here's another example. We have a full thickness defect from the patella. Again, this is our actual clinical cases. Arthroscopy performed, yes, many months later, just said some softening. Grade 1 of the patellar cartilage did not mention the full thickness defect. Maybe it healed, I don't know. This one, okay, there's a meniscal tear, but the cartilage looks fairly normal on this. It's a 3D sagittal PD image and this coronal PD fat set. It looks fairly normal, but arthroscopy done just 2 weeks later revealed a 1 centimeter full thickness defect with an actual picture. So they weren't making it up. Maybe they got an injury afterwards. Maybe we can't see it on MR. Okay, so the challenges. It takes up a small number of pixels. It's curved. It's a 3D volume. There's lots of discrepancies on interpretation. So you cannot just feed the raw images into the model directly. You have to optimize them. Now, remember we talked earlier about segmentation. There was that image I showed of like the vertebral, the spine, this lumbar spine. You saw the vertebral bodies, the discs and herniations getting segmented. So that's what they did here. This came out already 6 years or so ago. They developed a complex model that's a two-step model. First, they had a convolutional neural network segment out the cartilage and bone, and then it mapped the three-dimensional cartilage into a two-dimensional structure, same like turning a globe into a map. And then it used a second connected convolutional neural network to detect abnormalities within the cartilage. So here's a very complicated picture of kind of their pathway. The point is it's complicated. If you don't understand it, it's perfectly fine. I honestly don't understand it. But the point is there's two separate neural networks that are interlinked. And how did it do? So this I thought was interesting. They actually ran the model twice with slightly different results. And they found, sensitivity 80 to 84, specificity 85 to 87, which is the sensitivity was better than the residents, lower specificity. And I highlighted here the fellows because I'm the fellowship director and I'm always humbled by how amazing our fellows are. And the fellows actually did better than the machine, very high specificity, quite reasonable sensitivity. And they actually did better than the attending radiologists in terms of sensitivity. So I actually, I think that's a nice shout out to all the hardworking fellows out there. So that's a complex model. We talked about a simple model. We talked about a complex model. What are the limitations of AI models? So the main limitation is that they're trained for detecting one specific thing, classifying one specific thing, measuring one specific thing, or segmenting one specific thing. There's no general model to the best of my knowledge. For instance, there's no model that can like take an EMR and make a beautiful report out of it. And if there is a model, it's going to be trained for like, meniscal tears. And then if there's like something unexpected, some tumor, maybe signs of infection, it would probably break that model. There's also no image to text models created yet. The image output, the models output data, and then that has to be crafted into text with nuance that takes kind of the whole clinical picture and provides reasonable probabilities for the differential diagnosis rather than just a long list. Unusual findings that the model wasn't trained on may break the models. And we still don't know, can models be validated beyond the training data? Like, for instance, if it's a different manufacturer of MR, would the models still work? Or if it's a different patient population? And so that's basically it. And, as a summary, that AI in MSK radiology shows great promise in many specific tasks: detecting, classifying, differentiating, segmenting, measuring, opportunistic screening, image acquisition. We still don't know about the role of chatbots. And we spoke about the pathway for a simple model and the challenges of a complex model for more difficult tasks. However, despite all that progress, AI and MSK imaging is still piecemeal without a comprehensive general model. So for that, I'll have to rely on you. That's it. If we have time, I'm happy to take any questions, or I'll put them in the chat, or I'm just going to run back to the beginning because my email's on there. Where'd it go? There we go. So please feel free to send me an email as well.
Yeah, thank you so much, Dr. Mandell. That was really a fantastic presentation and I mean, really reinforced so many of the concepts that we hope our learners take away from this course. And I really love the description of the piecemeal nature of a lot of the AI applications that we see in the marketplace. When we've talked about this yesterday, we called this the narrow AI, but piecemeal is, I think, is a very good way of thinking about it.
I like narrow. That's good. Yeah.
All right. Well, yes, if anyone has any questions, please feel free to put these in the Q&A. But to keep within our time frame, I'm going to go ahead and pass this over to Dr. Andrew Smith, who is going to be joining us today from Memphis, Tennessee, from St. Jude, and is going to be presenting AI in pediatric imaging.